And moving forward to our next session. So, Dr. Asha, what is our next session about?
Dr. Pari, our next session is about the specialty talk. I request Dr. Frenil Mulim, Dr. Kalpesh Joshi, Dr. Devang Desai, and Dr. Pratik Sawat sir to come on the stage and chair the session. Our next topic about the next session is the glycemic control in the ICU, keys to individualized care.
Fear of septicemia requires aggressive control. Is 120 to 180 the only ideal goal?
તમારો આ ક્વેશ્ચનનો આન્સર આપવા માટે I would like to invite Dr. PIYUSH desai sir on the stage, and I also request our chairperson to introduce our next speaker. Over to you, sir.
Presently, he is working his own clinic, DESAI Diabetic Endocrine Clinic. I request Dr. PIYUSH Desai to talk on this topic.
Sir, I'll take your 1 minute. Sir,
Yeah.
there will be a buzzer
First
before.
of all, thank you, Anuj Bhai, for inviting me for this good Criticon. And very important topic, but oftenly I will say missed and less discussed topic, that how to control sugar. Because when we are talking about sugar, years back, સુગરમાં શું કરવાનું 4 યુનિટ વધારે આપ્યું કે ઓછું આપ્યું પેશન્ટ તો બહાર આવી જાય. Because now we are talking about ECMO, we are talking about multiple interventional therapy when patient is in ICU in a critical care situation. But if we are considering BP as a vital sign, respiratory rate as a vital sign, temperature as a vital sign, sugar is considered now as a 5th vital sign which decides outcome of the patient. So when we are talking about glycemic control, this is my financial disclosure for this talk. Novo Nordisk has sponsored. When we are talking about a person who is in the hospital, hypoglycemia, hyperglycemia, and glycemic variability, all three components are need to be controlled. And we have to balance between all these three to avoid adverse outcome. And most of the time, patient is in seesaw. Patient will have hyperglycemia. We are managing aggressively. I will come why it is happening inside the hospital. And suddenly there will be hypoglycemia. We are giving 50% dextrose. Patient is again having hyperglycemia. So patient is having risk of both extreme. As far as hyperglycemic emergencies are concerned, which are quite rare, common for type 1. In type 1, decay is very common. Almost 44 to 82% depends on the area where you are practicing. But for HHS, in type 2 diabetic who are neglected and who are dehydrated. Otherwise, HHS is not that common, but maybe sometimes in old aged patient with septicemia or dehydration, it may precipitate. And this is serious, acute, life-threatening thing, and which requires insulin. But in routine case, when patient is in hospital, first of all, patient may be non-diabetic and you have come across high sugar for the very first time inside the hospital. So first you have to decide if patient is having hyperglycemia, which is pre-existing, or is just a stress hyperglycemia. So go for HbA1c. If HbA1c is high, that's to your hospital. But if HbA1c is normal, or if say less than 6.5, and blood sugar is more than 140, it can be new onset hyperglycemia or it can be a stress hyperglycemia. But even if it is despite of pre-existing or new onset hyperglycemia, when patient is in critical care situation, no OAD is recommended, only on insulin therapy. Now, to give insulin IV or insulin subcutaneous, that depends on the patient's condition. So how we have to decide? We have ADA guideline, American Diabetic Association 2022 and 23 guideline, which is now revised and published again in 2025, which suggests that in critical care scenario, when patient is not maintaining BP, patient is in cardiogenic shock or septicemic shock, continuous IV infusion is the key to control their blood sugar. Now when we are giving continuous IV infusion, we all know that we give human actrapid or any other short-acting insulin, that is 50 unit in 50 cc NS, and we are giving through insulin infusion pump. But at the same time, IV insulin should be administered, depends on the protocol. Now what is protocol? We have multiple protocol, Texas City protocol, Portland protocols are there. But most important thing is, it is not about just reacting to the sugar every 2 hourly. Sugar is 5, we are increasing the dose. Sugar is less, we are reducing the dose. Patient is not eating, sometimes we are not, we just stop insulin infusion. It should not be the case. Actually, all this protocol is defined that what is the baseline sugar. So if patient is non-diabetic, we may start with 1 ml per hour when sugar is high, or even lesser than that we can start with. But every 2 hourly we have to check sugar. If patient is very critically, sometimes 1 hourly also, and depend on the next sugar level, which is how much it is reduced from previous one. We have algorithm 1, 2, 3, and depend on the algorithm we have to increase or reduce the dose. It is not just reactively stop insulin. As far as the starting insulin therapy is concerned, previously when before NICE guideline was not published, we were the tightest control is the better control. So we were targeting 90, 100, 110. But later on we came to know, after NICE guideline published, and the data behind that, backing that guideline, suggests that tighter control causes more hypoglycemia, which is actually attributing to worst outcome. But at the same time, if sugar level is more than 200, persistently more than 250, it is also causing, attributing to more adverse outcome. So what is the ideal level to maintain? Ideal level to maintain in ICU setting is 140 to 180. So neither tight control and nor a very loose or haphazard control. At the same time, if patient is in non-ICU setting, the recommendation is between 100 to 180. So one thing you have to keep in the mind, don't chase sugar less than 100 when patient is critically ill. And preferably if you are keeping between 140 to 180, that is fine. But if patient is otherwise stable, going for some cardiac procedure where tight glycemic control may improve outcome, you may think of keeping between 110 to 140, but not less than 100. And terminally ill individuals, advanced kidney failure, or patients who are at high risk of developing hypoglycemia, then less than 250 is acceptable. That's why 140 to 200, 180 is fine, up to 220 you may allow. Similarly, we have starting, these are the other guideline, that is RSSDI guideline, our own guideline to 2022, which is also almost similar to that 110 to 140 for cardiac patient, and otherwise it should be 140 to 180. Now, when we are titrating, you have started insulin infusion. Insulin infusion is given for 24 hours, 48 hours, even for 72 hours. Now after 2-3 days, if patient is fine, patient is improving, patient might be eating now. So you have decided to stop IV infusion, and now you want to transit patient to subcut therapy. Here, I think the biggest mistake we are doing in our routine practice. આપણે શું કરીએ? When we shift from IV infusion, what we does? Many times I have seen, when patient is transiting from ICU to ward, ICU માં infusion protocol ચાલે છે, then they stop. Then patient will go to ward, and after 4 hours, 5 hours, pre-dinner sugar will be checked. So there is no insulin in between. Second mistake, we are giving by default, by book, વર્ષોથી જે આપણને ભણાવેલું છે, IV infusion પતી ગયું, then we start act rapid. I am talking with brand because it is by default in each of us pen, on our pen, act rapid. Now, what will we do? We are giving 3 times, 4 times act rapid. But what about basal insulin? When patient is critically ill, the component should include basal insulin also. If patient is non-critically ill, then basal requirement will be much more. And when patient is coming to our OPD, their basal requirement is almost half or more than half also, many a times. So this is very important that you have to count total daily dose of insulin therapy which is given in the last 2 or 3 days. Why? This may cause problem because when you start insulin when sugar level is 400, insulin infusion requirement be very high because of glucotoxicity. Now after 2 days, glucotoxicity is down and suddenly your insulin requirement is down by 4 to 8 unit per ml per hour. Now it has reduced to 1 to 2. So I will suggest take last 4 to 6 hours data, multiply it by 4, 6 into 4. So you will have rough idea of last 24 hours requirement. Then divide it into 50-50. 50% should be basal and 50% should be bolus. And bolus should be decide on how much patient is eating. Now, when to shift patient from IV to subcut? If patient is having glucose level which is fairly stable. Fairly stable means 140 to 200, this is fine. Resolution of any acidosis or decay whenever patient is having. Hemodynamically patient should be better and preferably patient should not be on vasopressors which may derange their blood sugar. Patient is at least has started eating. I will not say patient is eating fully, but patient has started eating. And patient, the IV drip rate in last 4 to 6 hours or 8 hours is fairly consistent and no large variability. On the other side, if patient is having sugar level which is fluctuating more and if IV drip rates are variable, highly variable, don't be hasty to shift patient on subcutaneous therapy. And if patient is stable, you may shift to subcutaneous insulin. Now this is another mistake which is happening when we are transiting from IV insulin to subcutaneous insulin, that IV insulin is having T half-life which is less than 5 minutes. So ideally, the first subcutaneous insulin dose should be before stopping IV insulin. So as per the count, you have to adjust this thing and you have to give insulin infusion. At the same time, if you are changing IV to subcutaneous insulin in the middle of the day, because traditionally basal insulin we are giving at night, but you are changing subcutaneous, કારણ કે ICU માં કેવું હોય કે નાઇટમાં આપણે બહુ છેડછાડ નહીં કરીએ. If patient is fine, usually the shift what we plan in the morning. અને morning ઘણી વખત doctors around આવતા afternoon થઈ જતી હોય. So in the afternoon if you have shift, then basal insulin, the first dose of basal insulin, at least half dose of basal insulin should be also given at the time when we are shifting patient from IV to subcutaneous insulin. So these 3 components are very important. First, basal insulin, because it will correct fasting state. Bolus insulin, which is requirement for meal time, but at the same time, third part is correction dose. Now, why correction dose is important? Because in routine case, we are just doing sliding scale. કેટલું sugar છે તે પ્રમાણે insulin આપવાનું. And despite of long time teaching, we are repeating the same thing in our patient who are in ICU or in hospital setting. So, sugar આવ્યું. We have given insulin shot. Now, there is no insulin given when hypoglycemia is there. So, after giving 20 unit, 400 sugar, 20 unit we have given. Now, patient has developed 75 sugar. Even today, when I get call from hospital for my diabetic patient whom I am managing, 75 sugar, morning 6 o'clock, assistant doctor or RMO has called me. I have told 8 unit. Sir, 75. એને એવું લાગે કે સાહેબ ઊંઘમાં છે ને 75 ઉપર 8 યુનિટ આપવાની કોશિશ કરી રહ્યા છે. એટલે પાછો ફોન કરે 5 મિનિટમાં, સર 75 છે, 8 યુનિટ આપું? But if patient requirement is 8 unit, we have to give 8 unit at 75. We have to stop that peak which is happening after food. We are not just reacting things. So sliding scale is very problematic because it is not individualized. It is more of a reactive practice. It is non-physiological. So what important is basal at night to correct fasting, and mealtime bolus should have correction dose also whenever it is required. So ideal insulin regimen requires various insulin. Now PIYUSH is the faster acting insulin aspart, which is the fastest short acting insulin available, which is almost physiological. It correlates with the physiological peak of insulin. Then comes all other rapid acting, that is Lispro, aspart and glulysin. Then this is our regular human insulin, which we are using for years together. And for long acting, NPH insulin, I will say hardly now we are using in ICU setting NPH insulin. Most of the time we are giving, Detamir is also out of session, that is glargine insulin and ultra long acting degludec insulin. U100 glargine is almost, I think, routinely we are using, but now we have U300 glargine and we have insulin degludec also, which are ultra long acting insulin with no peak and with the least variability. So which is very important, that if you are using basal bolus therapy, try to use as faster acting insulin as possible, like rapid acting insulin and analog or faster acting insulin analog, and the basal insulin should be longest enough. So you can use U300 glargine or even degludec, because degludec is having very less variability. So this is insulin degludec in comparison to glargine U100 and U300. That time of onset of action, કારણ કે ઘણી વખત લોકોને શું લાગે, because it is longer acting, time of action onset is also very slow. No, this is very fast acting and you can use safely without staking. And the least nocturnal hypoglycemia, least severe hypoglycemia is noticed with insulin degludec. So you can use this as a basal insulin. And these are the data where it is compared to U100 and U300, and it was found to be superior as far as less variability and less hypoglycemia risk is concerned. So it is having quick onset, minimum variability, and it is peakless and flexible doses. Now why this flexible doses is important? मैं कहूँ ना कि if you have given basal insulin at the middle of day and now you want to repeat at the night, and if you want to repeat this basal insulin at different time, this insulin is having flexibility of plus or minus 6 to 8 hours. રાતે લીધું છે છતાં પણ તમે સવારે બેઝલ ઇન્સ્યુલિન આપી શકો છો. If you want to shift the time of basal insulin, because see, in hospital patient is not stable. Today patient is stable, it is possible tomorrow patient again become unstable. So you may have, if you have flexibility, you can manage this very well. And similarly, when you are giving shortest acting insulin or rapid acting insulin or regular insulin, the shortest or fastest acting insulin is as physiological as this. You can see the routine human insulin comparing PIYUSH, the time action profile, actually onset of action is very fast, within 10 to 15 minutes. Peak occurs at 1 to 1.5 hours, though it is written 1 to 3 hours, peak happens at 1 to 1.5 hours. Because this is one of the commonest thing. Again, when patient is ill, what is the problem? Are we giving human insulin half an hour before their food in hospital? No. Is patient eating properly as per you have thought and you have given insulin? No. If you are giving this faster acting analog, you can give just after food also because of its rapidness. And which is very practically feasible and explainable thing, and that is very important because it improves postprandial control, and by doing this thing, not only it reduces the postprandial peak, it reduces late postprandial hypoglycemia also. And if you want to switch over, this insulin also can be given IV. But that depends on your practice, your availability in the ICU and hospital setting. You can use Actrapid IV, and later on you can shift on FIAS also, or you can give with any other insulin like normal saline also. It is having faster acting action, it is causing lesser hypoglycemia, and again, flexibility of giving insulin in our hospitalized patient. So this is why we can monitor, manage patient with hypoglycemia in ICU setting as well as non-ICU setting when patient is critically ill. And just 3 messages from my side: use basal bolus therapy, use correction dose, and preferably use insulin analog, because flexibility is the time now we have to adapt. We just cannot go on giving insulin therapy what we were used to give 10-15 years back. Thank you.
Thank you very much. Any questions from audience? Conventional, short-acting, no rapid, and FIAS. But
Yes.
when we use in ICU in infusion, is
There
that
is no
make any
difference.
difference? Because
No
cost
difference.
is very huge.
Yes, that's why
For
I told.
basal bolus it is okay, but when
Yes.
we use in IV infusion,
I-
it make any difference?
I also don't prefer giving, because unnecessarily it increases the cost of therapy. So though it is traditionally explained that there is no transition is required, but I feel there is no difference if you give FIAS or Actrapid when you give IV. So use Actrapid only when patient is using inside hospital infusion. But when you shift, it is better to use such type of analog. Definitely.
Thank you.
Thank you. Thank you so much, Dr.
Excuse
PIYUSH
me,
Desai.
one question from there.
Yeah. Yes? See, fluid therapy depends on the patient condition. If patient is having decay, requirement will be different. If patient is having hypovolemic shock, requirement will be different. So fluid therapy, actually it's a altogether different part, because which type of critical illness is there depends on that fluid therapy is decided.
Previously, we were giving GKI infusion, glucose, potassium, and Actrapid insulin infusion for management of blood sugar.
No. That is, you are taking wrongly. If even today, for severe hyperkalemia, you may use such type of thing, but in routine practice, no, we are not using. Even now, patient is on insulin and patient has developed hypoglycemia, we start dextrose fluid from different line, and we just continue insulin infusion. We don't mix this together, because we have option to putting 2 line differently in a separate line. So dextrose to be given separately. So that combination is not for glycemic control at all.
Thank you so much, sir. Thank you, sir.